Hello and welcome to Focus on Health. I'm your host, Peggy Mello. Today's guest is Dr. Rob Brass from the Brass Eye Center in Latham. Welcome to the show, Dr. Brass.
Hi, Peggy.
Hi. Why don't we start out with you talking about your background. Tell us a little bit about your practice.
Okay. I'm a board-certified ophthalmologist. I did my medical education at the University of Wisconsin, my residency training at New York Eye and Ear, Westchester Medical Center, and then I did a special year of training in just cornea, external disease, and refractive surgery back at the University of Wisconsin. I came to Albany in 1997 and started my own practice in 2000. I'm at the Capital Region Eye Center. It's on 713 Troy Schenectady Road. I am also an associate clinical professor with the medical center, work with residents 1 day a week, and I'm in private practice all the other days.
Great. So, we're here to talk about eye disorders. Why don't you tell our audience how we see?
Okay. If you think about the eye is like a camera. The surface of the eye is the cornea. That's like the window the light comes through. Then there's the lens of the eye. The lens is actually inside. The light passes through the lens. And between the cornea and the lens, the light should get focused on the back of the eye. That's the retina. That's basically how we see. The light goes to the retina. The retina transforms that into information the brain can understand, and the brain kind of translates that information.
And a lot of things can go wrong in all of those processes, right?
You know, it's amazing. I went to 4 years of medical school and 3 years of ophthalmology training plus a year of residency just for one little eye.
Yep. Okay, so why don't we start with eye examinations?
Okay.
Why don't you talk about those and maybe how often patients should get them?
You know, it's interesting because there are children and kids. If you have a family history of a lazy eye or some other eye problem, if the child's born prematurely, those things are special circumstances that would certainly have you aware that maybe the child should be examined early. So if there's any kind of family history of eye problems, those things should be checked early.
Right.
Otherwise, preschool is a good age for most kids. Again, unless you notice their eyes are crossing, they seem to be really clumsy, things like that. Because at preschool, then the child is A, more behaved, they're going to interact better, and B, they might even be able to participate. So when we cover one eye, have them look in the distance, they should be able to give us a response as to what they're seeing. Again, if there's a problem or a concern, we can always do things sooner, but in the normal, general, healthy age child, preschool is a good age. That's when we typically will find people who are nearsighted or farsighted or have astigmatism, and we can talk about that after. For that window of health, say from when we're between our early teenage years right up through our 20s and 30s, right up to around 40, most people don't think much about their eyes, and they probably should. I think every 2 years or so is probably a good range of time to have an eye exam to make sure things are healthy.
Okay.
Again, people who wear glasses get their eyes checked more often. People who don't. I'll see people in their 40s and 50s who've never had an eye exam because they've always seen well. As opposed to the nearsighted people, you know, they go every year or two to get new glasses.
Okay. Now, what about farsightedness?
Okay.
What exactly is that, and how does that happen?
You know, it's real interesting. I think because we're New Yorkers, we all tend to be a little sarcastic, right? Farsighted means you can see far. So typically, from the time you're a child until the time you get into your early 40s, you can see well in the distance. And you can still see well up close because we all can see well up close into our 40s. The farsighted person is the first person, once they reach 40 or so, to notice they can't see up close. They have to, their arms get too short, they have to push things out. The nearsighted person is just the opposite. At an early age, they can't see as well in the distance as, say, a farsighted person can without glasses.
Right.
And that's because of the way the light focuses on the eye. And I can kind of show you that on the eye model. If you think about the way the eye, the cornea, that's the clear part on the outside, is shaped. Remember back in grade school, we talk about when parallel light rays hit a curved surface. Does that sound vaguely familiar? Right? You don't have to be a physics major. But when parallel light rays hit a curved surface, they come to a focus at some point. Now, ideally, when the lens of the eye is relaxed and we look at something in the distance, light rays hit the cornea, which does most of the focusing, and the light rays focus right here on the retina. Well, let's say that you are farsighted. The farsighted person, the light rays don't come in focus at the retina, they come in focus at almost behind the retina. We can use the lens of our eye to do some extra focusing and almost pull the light rays back into focus. All right, so it's a kind of an esoteric concept, but the bottom line is the farsighted person can use the lens of the eye to help them focus and give them really crisp, clear vision in the distance. The only problem is, as we go through life, once we get closer to 40, the lens isn't strong enough to help us focus the light anymore.
Okay.
So that for no good reason, farsighted people don't see well in the distance much past 40 or 50. And that's because they were using their lens to help them focus, and the lens gets weaker. The opposite is true for the nearsighted person. Cornea has too much curve. The light rays focus in front of where the retina is. And you can't do anything to relax the lens or change the shape of your cornea, so you're forever nearsighted. The only way to make that more clear is with glasses or contact lenses. Now, while we're on that subject, let's talk about astigmatism. Astigmatism, ideally the cornea is perfectly round. All right? I think doctors talk in big words to confuse people, make themselves sound smarter than they really are. If I said your eye is a little oval, you'd know exactly what I meant.
Right.
Astigmatism, for all intents and purposes, is just another word for oval. So basically, instead of the cornea being perfectly round, the cornea is off-round. It's more football-shaped or oval. Well, when light rays hit a oval surface, instead of coming to a point focus, they come to a blurry circle. So when you get something to correct your astigmatism, all that's doing, whether it's glasses or contact lenses, is correcting the ovality to make it more circular so the light rays come to a point focus.
So eyeglasses or contact lenses can correct astigmatism?
Yes, and laser vision correction as well. And you know what? We have new lens implants for cataract surgery. So if you have a lot of astigmatism, we can even choose to do that. So there's a lot of ways to skin that cat.
Okay, so let's talk about eyeglasses.
Okay.
I know with my very strong prescription, if I were wearing eyeglasses with plastic frames, that my ears would be aching right now. Do you want to talk about the difference between plastic lenses
Sure.
and any other type of material?
Well, it used to be that all we had were glass lenses. It used to be made out of crown glass. Then we started getting into polymers, plastic. Remember, I guess, the movie The Graduate, right? Plastics. Well, plastics are being used for everything now. And we have different types of plastic with different indexes of refraction. What that means is, for a given thickness, it can bend the light a certain amount. Crown glass, which was the reference point, if you will, had an index of refraction of 1. So for any given thickness of crown glass, it would bend the light a certain amount. Everything is based on that amount. Certain plastic or polycarbonate lenses can bend the light more per given thickness than crown glass. So let's say you have a millimeter of crown glass and it bends the light 1 unit. You may have a polymer or a polycarbonate lens that can bend the light 2 units for the same given thickness. So with a plastic lens, you can get a thinner lens that would do the same correction of your vision than a thicker glass lens would.
Okay.
So we don't really make eyeglasses out of glass anymore. Most eyeglasses are made out of polycarbonate or other plastic type lenses, which are very clear. Also, they're very safe. They can withstand foreign bodies hitting them. They don't shatter into a million pieces. They tend to break. And they break in a controlled fashion so they can actually be protective. So wearing glasses is actually a protective thing as opposed to a non-protective thing. It's not like you have to take your glasses off during sports or things.
So when somebody has a Pinnacle lens, is that polycarbonate?
A Pinnacle lens is a brand, right, of a polycarbonate plastic lens.
Okay.
And then
Now-
progressive lenses are a discussion between single vision for distance. Then there's bifocals. What a bifocal does is gives you 2 lenses, bifocal, two lenses. The lens on the top helps you to see in the distance. Then you look down to a certain point, and then you change lenses. And for those of you who worn bifocals, you know there's like an image jump, because you can tell that you're no longer looking in the distance. It's like, boop, and now you can see up close.
Well, I say people use the computers like...
Yeah, they have to tilt their head back to get that image.
Yeah.
That's why people go to trifocals, right? Because if you have a bifocal, that gives you a focusing distance, say, from here to here. Then you have your distance glass, which focuses from the distance to out here. There's a hole in the middle. Well, the trifocal lens is somewhere between the bifocal and the trifocal. Then we get into the newer, better way of doing vision correction, which is the progressive bifocal. There's no line in the progressive bifocal. It gradually changes as you look through the lens. So at the top part of the lens, you've got your distance correction. As you look down a little bit, it brings you in a little bit more, until as you look down more in the progressive bifocal, then you're looking up close. The only potential drawback with that is that some people have a little bit of trouble adjusting to them. But I would tell people that if it's been a while since you've tried them, they come out with newer, better progressive bifocals almost every year or so. So if you tried progressive bifocals 6 years ago and you couldn't adjust to them, it's worth trying again, because a lot of the problems with people feeling a little woozy or a little unstable have been fixed.
Very interesting. Now, what about contact lenses?
Okay. You know, contact lenses are very interesting. I'm going to take them all out again. Remember, we talked about the fact that vision is really dependent on the shape of your cornea, all right? We all have a lens in our eye, and everyone thinks the lens must do a lot for our vision. Honestly, when we're looking in the distance, ideally the lens of the eye is relaxed. So it's just the shape of the cornea that determines whether you're farsighted, nearsighted, or have astigmatism. A contact lens is a device, a lens, that we place over the cornea to give the cornea a better shape, to give that patient better vision. So for example, with the nearsighted cornea, that's the cornea that has too much curve. When you place a contact lens on your eye, what you're doing is you're placing a lens of lesser curvature over your own natural cornea, and then that basically minimizes the curve of your cornea so you can see clearly. For the farsighted person who needs to use the lens of their eye to focus, remember, ideally the lens of the eye is relaxed. For farsighted people, they may need to use their lens, and that works for a limited time. Once you get into your 40s, the lens can't work for you anymore. You need to wear glasses or something else. Contact lens would give more curve to the cornea to make the farsighted person be able to focus better. And if you follow the discussion about astigmatism, basically if the cornea is irregularly shaped and I place a lens on the eye that makes up for that irregular shape, that oval shape, then you can see clearly. So contact lenses basically cover the natural shape of the cornea to give the patient better corrected vision, and the ophthalmologist or the eye care practitioner helps the patient to identify what the best lens would be to make up for the shape of their cornea.
Now, what about the different materials available for contact lenses?
You know, it's pretty exciting. It used to be that there were only hard lenses. Okay, I know when I was 16 and I was dying to get contact lenses, that's all they sold. As a matter of fact, it's funny because when I was 16, they said, the doctors were almost like, well, I'm not sure if this is really a good product or not. You know, they're kind of like a new concept of putting something on your eye. But they were only hard lenses. Now, think about it. A hard lens is made of a rigid material called PMMA, polymethyl methacrylate, and it's a breathable plastic that allows air and things to pass through.
Okay.
And then you can basically see. Then they got better and better materials after that, even more breathable and more permeable to oxygen and more friendly to the eye. Hard contact lenses are great products, and anyone who wears hard contacts know they're great.
Now, what's the breakdown of what percentage of people use hard contact lenses? Who uses soft?
It used to be that the only lenses out were hard, but hard lenses take some getting used to. When you put them on your eye, you feel them. All right, you have to develop a tolerance toward them.
Wow.
Well, when they got better and the materials were more available for soft contact lenses, soft contact lenses are a lot easier for people to get used to.
That's all I've ever used.
And they're a lot less expensive up front because a hard lens can cost $80 to $160 for one lens, whereas soft lenses end up costing like $5 a piece. But if you think about it, you change your lenses every 2 weeks or so, you're going to be spending more on soft lenses than you are on hard.
Well, how long does a hard lens last?
Hard lenses can last years.
Oh.
Okay, if you don't lose them.
Or your prescription doesn't change.
Well, and that's just it. You know, typically our prescription doesn't change much past our early 20s. All right, there's two big changes, right around puberty and then right again near our early 20s. You know, as an aside, laser vision correction, we don't want to perform on somebody whose vision is changing. So the FDA makes it at least 18 years of age, but in my experience, you want to wait until you're at least 21 or 22 because there tends to be that second little blip. But once you're much past 22, your vision doesn't change as much. Now, that's not true for everybody, but for most people. So if you had a hard contact lens that you got when you were 25, you could probably wear it for a couple of years, easy, and not have to change it.
Do they tear less frequently? They're hardier?
Hard contact lenses are very hardy. They don't tear, okay? They can break. I mean, you can actually crush them, right? Because they're literally rigid, so they don't flex. They don't tear. So they're distinctly different than soft. Also, hard lenses are very small. They're only about 8 to 8.5 millimeters in diameter, whereas a soft lens is 14 or 14.5 millimeters in diameter,
That's
almost
humongous.
twice as wide around. So if when a hard contact lens wearer looks at a soft lens, like, I can't put that thing in my eye.
Right.
And when a soft contact lens wearer looks at a hard lens, they're like, oh, they're so tiny.
Do you want to talk about the different types of soft contact lenses? I know there's daily ones and then 2-week ones, etc.
Yeah, basically, you know, it all comes down to the polymer, the type of lens material that the contact lens is made out of. And it kind of makes sense. I mean, the goal is to have a contact lens that is breathable and wettable, because your eye has to stay moist. And a lot of us who have dry eye, or if we're on planes or in dry environments, know that when we have our contact lenses in, by the end of the day, they can really bother
Well,
us.
if it's an overnight flight, you're in big trouble.
Right?
Take
So the contact lenses are broken down into different types, and they have to have a certain amount of oxygen permeability so that they can be worn for an extended period of time.
Right.
Because if they don't allow the eye to get the oxygen that it needs, then the cornea can swell and that can become a problem.
Right.
So that's really the big issue with contact lenses and extended wear, is the oxygen permeability and the breathability of the lens, if you will. So it used to be there were only a few out, now there's tons of different lenses out there for people with dry eye, people who want to wear extended wear. Now, you asked about daily as opposed to 2-week, opposed to 3-week, opposed to 1 year.
Right.
The lenses that last a year are typically a little thicker, a little bit hardier, because they have to stand up and last for a year.
Right.
Honestly, there are very few people wearing just single yearly lenses. The majority of people wear either 2-week or 1 month or so lenses, because cost-wise it's better than the daily disposable lens, but you still get the benefits of having a fresh lens every 2 or 3 weeks or every month or two, however your replacement goes. And in terms of the different polymers that make up the lens and your eye care provider for your own special needs, you may need to wear a different type of a lens, all right? But they're all the same in terms of, 14.5 millimeters in diameter, have a certain shape, and do the same certain thing. They impart a different shape to your cornea so you can see clearly. So it's really individual. So for example, I wear daily disposable contacts. Okay, I open up the foil pack, put it in my eye in the morning. At the end of the day, and this is something I recommend to everybody who wears contacts, always put a drop of artificial tears in your eye before you take your contact lens off.
Oh.
Have you ever noticed when you take your lens off, it kind of sticks to your eye? That can't be good. You're giving yourself a small abrasion. So if you put a drop of artificial tears in your eye, then you're lubricating the lens. Concept is, I'm wearing daily disposable because my eyes are dry, and the 2-week disposable lenses, after a couple of days of having cleaned them and putting them in the soaking solution, putting them back in my eye, the lens isn't as breathable, isn't as wettable, and it becomes less comfortable in a short amount of time.
And we can kind of feel
Oh,
after 2
yeah.
weeks that it's been 2 weeks. It's time to throw them out.
Exactly. So that basically is an overview of why there's daily, why there's the 2 week or the 1 month. There's also, I don't want to say cleanliness, but less issues with infection or bacteria when you change your lenses frequently.
Mm-hmm.
Because, a 1-year lens has more risk of getting bacteria in the pores, things like that. Care of contact lens cases, all right? That contact lens case, they've done studies where when you culture that thing, you can grow a myriad of bacteria and things like that.
So how often should we replace the case?
The case probably should be replaced as often as you replace your bottles of solution. Now, another thing, topping off your solution. When you take your contact lens out, put it into solution overnight, then in the morning you take your contact lens out, put it in your eye.
Mm-hmm.
What do you do with the solution in the case? Are you emptying out the solution, cleaning your case on a daily basis?
Well, I usually dump it in the sink, but I don't usually clean it.
Okay, that's better than most, because a lot of people just top off the solution.
Oh, no.
Okay, and then they use the rest of it the next day, and they use the rest of it the next day. Those people are at a greater risk of getting a bacterial corneal ulcer than people who dump it out and let it dry. I mean, you don't necessarily have to wash it under tap water, because you could argue that you could get something bad from the tap water. So if you just dump it out and let it air dry over the day, that's probably the best way to go.
Oh.
But change your case with some frequency. I mean, I bet if a lot of people look at their cases, they'll notice a lot of grimy stuff on those cases. That's why a daily wear lens is nice, because you don't have any muss, any fuss, no solutions, no cases.
Interesting.
Easier to travel. So while they are a little bit more expensive up front, you don't have to buy solutions, you don't have to deal with the cases, and there is the ease of use, because you're not spending that time at night where you have to go through that regimen of taking your contacts out.
Yeah.
Now, one thing I recommend to everybody, you should not sleep in your contact lenses, all right? I know as a fact everybody wants to wake up and see beyond the bed covers in the morning and all that stuff. That is the leading cause of corneal ulceration that I see, and I see it once a week, because I'm the guy that gets the patients with corneal ulcers. And, you're healthy, you're capable, you can do lots of things, you can take your contact lens out at night. You will greatly diminish your risk of getting a vision-threatening ulcer.
Very interesting. Now, there's a common question. People want to know when their contact lens prescription is minus 575.
Right.
What are they in the 20/20/2100 realm?
The minus 575, what that number is diopters, all right? So it's a unit of measure. Just like, an inch is a unit of measure. So if I say to somebody it's 2 inches, everybody in America at least knows what 2 inches is, right?
Right.
A diopter is the focusing required to focus an image at 1 meter. That's 1 diopter. So 2 diopters is basically the inverse of 1 over that number, meaning 2 diopters would be focusing an image at 1/2 a meter. 3 diopters at 1/3 of a meter, 4 diopters at 1/4 of a meter, that kind of thing. Now, it doesn't necessarily go right over to the Snellen visual acuity, which is 2400, 2200, 2100, but somebody who is a -1 can probably see around 2040 or so. So somebody who's a -2 could probably see about 2080 or so. Somebody who's about -3 is probably about 2160, and then -4 is probably beyond 2200, 2400. 2400 is the big E on the eye chart. Okay, so if you're much past a -3 or a -4,
That's me.
you're not even seeing 2400. You're not even seeing the big E on the eye chart.
Okay, so 2400. What does that mean?
Well, again, people like to just quantify things. I mean, either you see or you don't. Driving vision is probably the most important number, and that's 2040. So when you go to the Department of Motor Vehicles and they ask you to read that eye chart, okay, read the 4th line, you have to see that to drive without glasses. That's 2040.
Okay.
That's really a very important line for us, because we have a lot of people coming in with those driver license forms, things like that. The rest of it is just as, my eyes are worse than your eyes kind of thing. Like, without my contacts, I only see X amount, whereas without my contacts, I only see Y amount. It's really just discussion. I mean, I see people who are very nearsighted who can just barely see beyond their hand. All I care about is how good I can correct your vision. I want to be able to correct your vision at 20/20 with the appropriate glasses or contacts. As long as I can do that, your eyes are healthy. It's when I can't do that that I have a concern.
Okay. Now, the different surgeries that are available, what are they for vision correction?
Okay. The big thing I think most people hear about and talk about is LASIK.
Right.
And again, going back to the model, I can kind of show, because it all talks again to the cornea. Remember, the cornea is the first window. And if you notice, it is curved. So we don't think about the cornea as being like a lens, but because it is a curved surface, it does the majority of the focusing. And as I also said before, ideally the lens of the eye is relaxed when we're looking in the distance. So the lens shouldn't have anything to do with our distance vision. Now, just for completeness sake, remember, for farsighted people, they are using the lens of their eye. So we take into account whether they're over 40 or under 40. But we're going to put the lens down because we're going to pretend the lens isn't even there. It's just the shape of the cornea.
Okay.
Well, remember, if you're farsighted, you don't have enough curve, the light doesn't come into focus by the time it gets to the retina, so we have to steepen your cornea. We can use laser energy. That's what the excimer laser does. LASIK is laser-assisted in situ keratomelusis, which is a fancy word for just changing the shape of the cornea.
Okay.
Okay, so that's all laser vision correction is changing the shape of the cornea. For the farsighted person, we can make the cornea steeper so it does more focusing. For the nearsighted person, we use the laser and we flatten the cornea so it does less focusing. Now, when we do traditional LASIK, that involves putting a suction device on the eye and cutting a very thin flap of tissue. If the cornea is 550 microns, we cut a flap of tissue that's about 130 microns. But you can think about, going over to Price Chopper or Hannaford's, cutting bologna, right? Thin slices. Okay, I mean, it's the same kind of concept. We're just cutting a thin piece of tissue here.
Okay.
Fold that over, apply the laser energy, fold it back.
Oh.
Now, the beauty of that is we haven't interrupted the skin on the surface of the eye. Less pain, quicker visual rehabilitation. Potential problems include creating the flap getting knocked off, getting wrinkles or folds, things like that. Another way of creating the LASIK flap is called all-laser LASIK, or intralase. That's available with very limited availability in Albany. Some people go for it. It is a lot more expensive, and there's still discussion as to whether it's really worth that expense or not. Another way of applying the laser energy is no flap at all. We remove the skin from the surface and apply the laser energy directly to the surface of the eye. That is safer in one regard because there's no flap. However, the vision doesn't recover as quickly because now we have to wait for the skin to heal, and it can be associated with more discomfort than traditional LASIK. So it really is individual to each person. Also, your cornea may not be thick enough to have traditional LASIK.
So basically people go for a consultation and then they find out if they can do it.
And they should be given the information by the surgeon as to whether or not they can have A, B, C, which may be better for them. And then, of course, it's individual to people. If you're in an environment where somebody might rub against your eye like a baby with a young mother. I've seen young mothers with their flaps dislodged from babies because babies have no personal space, right? They just grab at you. Gardeners knocking their flap off when they've been gardening. Police officers, in scuffles, things like that.
Right.
So LASIK is a great procedure for the right person. Surface ablation, which we used to call PRK, which involves no flap, is also a great procedure for the right people. And that's basically the state of laser vision correction. Now, there are implantable contact lenses, all right, where we actually insert a lens into the eye. It is not as popular because it has significant risks,
Oh, boy.
and eventually that has to be taken out when you have a cataract at some point in life. So they're out there, but they're not a huge share of what people do for permanent correction. So.
Okay, so next, all right, there's so much more to discuss. We have a number of topics that we're going to cover in our next show, which is going to be eye surgery.
Right.
And the topics are going to be glaucoma.
We can talk about glaucoma. We can talk a little bit about macular degeneration.
Mm-hmm.
We can talk about diabetic retinopathy. We can even touch on retinal detachments.
Okay.
And then in the second half of the show, we can talk about cataracts. And I even have some footage of live cataract surgery. Obviously, it's not live at the time because it'll be
Right.
taped.
Yeah.
But it's very interesting because I think the whole tape or the whole MP3 runs about 11 or 12 minutes. And that's a start to finish cataract surgery.
Okay, great. Sounds exciting. And just further information, you have a couple of associations or organizations you want to mention?
For people who like to use the internet, the American Academy of Ophthalmology or
Okay.
the American Society of Cataract and Refractive Surgeons,
Okay.
those are organizations that ophthalmologists belong to and would have a lot of information. I have a website, brasseyecenter.com,
Okay.
and that has a lot of good information. And then it has information on how to get in touch with me at the Capital Region Health Park.
Mm-hmm.
And our phone number is 782-7827.
Okay. Thank you very much, Dr.
It's been a lot of fun. Thank
Take
you.
care. Thanks for watching. We hope to see you next time on Focus on Health.